Okay, so hip examination. So what will be the chief complaint of the patients who are coming with?
Hip pain.
Okay, pain. Then any deformity. Yeah, any limb length discrepancy typically. Okay, sometimes malunion femur they can present with discrepancy. Okay, so what do you start? So it's always same thing. Look, feel, move. Special test. So look, what do you do?
Gait.
Gait. Okay, so back and forth. Okay, and gait, important thing is make the patient walk back and forth and make sure that you are not really pretend that you're not observing the patient, so he doesn't pretend the gait. Okay. Can walk normal. Okay. So what are the gaits that you have to keep in mind when you are doing hip examination? Antalgic. Antalgic gait can be due to hip OA or some pathology which gives inability to bear weight on the joints. So antalgic means there will be an increased stance phase on the unaffected limb. It means the contact between the ground and the patient's foot will be increased on the unaffected limb. So if my right is affected, this is how they will walk. Increased stance, and it will be shorter. Okay, they will flex the knee, etc. Short limb gait. What is short limb gait? So let's say due to some malunion, some fracture pathology, there's some reduction in the length of the one limb compared to other. They will present short limb gait. So short limb, how to find? The shoulder and pelvis will tilt to the normal side when they walk. Okay, that is short limb gait. Okay. Then, what other gait do you have? Trenel-Lundberg. Trenel-Lundberg. So how to know Trenel-Lundberg? So Trenel-Lundberg means when the patient walks, one unilateral pelvis will tilt each time they walk. The tilting pelvis is the normal pelvis. So this is due to the weakness of the abductor muscle, okay, gluteus medius. So when you are walking, both sides of the, actually you can bring that one. So Trenel-Lundberg gait means when you are walking, remember the gluteus medius needs to contract to abduct the hip each time you walk. So let's say one side is weak, okay. So it won't be able to abduct the pelvis. So what happens is, so let's say you have, this is right pelvis, left pelvis. Let's say this is pathological. This is having some abductor weakness, probably due to L5 radiculopathy, some muscle tear, okay, some superior gluteal nerve injury which innervates that muscle. The normal pelvis will go down so that it can give leverage to the abnormal pelvis to go up. So it's like a seesaw. Okay, so this will go down so that the abnormal one can go up. So each time you walk, the normal pelvis will just drop. Bilateral Trenel-Lundberg gait is waddling gait. You can get in DDH, okay, or bilateral pathologies, bilateral weakening, etc. So these are three gaits you have to look: antalgic, short limb, and Trenel-Lundberg. Then you anteriorly inspect. Face anteriorly. So what can you know anteriorly?
The attitude.
Attitude. You are arrogant. Kind, arrogant, what else?
Any
It means look at anatomical position. Okay, sometimes they might have fixed flexion, okay, deformity, etc. So look for what? Attitude, pelvic tilt, shoulder tilt, any deformity, symmetry of patella, superior border of patella. Look at the symmetry. Then
Any
swelling, infective pictures, swelling, scars, sinus discharge, erythema, scars, yes, surgical previous trauma. Because you must know when someone comes with complaint of hip, let's say hip pain can be even due to knee. Sometimes knee OA can radiate. It could be due to spine also. So you must look at an overall inspection. Then lateral, you must go, of course, you must inspect laterally. So laterally, what can you see?
Any fixed flexion.
Fixed flexion. Okay, pretend like flexing the hip. Okay, fixed flexion deformity, hyperextension of the knee, and importantly, don't forget to look if there's any excessive lumbar lordosis. Okay, so some normal lordosis will be there. Talking about excessive means there's an excessive lumbar lordosis. Why is this important? You'll come when we look at Thomas there. So look at those points. Then of course look at the popliteal if they are on the same popliteal fossa, the level of the popliteal fossa. Then look, feel. So how do you do palpation? Yeah, so you want to make the patient lie down, but before that, it's always advisable to see if the patient can squat and stand. Squat. Okay, great. This will test for the stand up. This will test for the muscle power over all the minutums of the lower limb. So it must be at least like well, maybe 3 or 4 if the patient can squat and stand. The muscle is, power is at least 3, or you can even say 4. Then he lies down. How to need few people, right? You can come closer. Right? Okay, so you want to palpate. So what do you start with? Warmed. Warmed, right? So you check. Of course, you give adequate exposure, but for the modesty of the patient, we don't want to give exposure. Warm dorsal of the hand. So you palpate around the hip joint to look for warmth. Look for infective picture. Sometimes you can even get some trochanteric bursitis, okay, septic arthritis, etc. Then you slightly ask the patient to tilt. Okay, you want to give good exposure like this only. So you palpate around the hip joint. Okay, the joint line. Okay, greater trochanter. Okay, then you want to palpate for the posterior parts, posterior spine. Okay, inguinal ligament. So how to check for the inguinal ligament and ASIS? So you want to show the examiner on how you want to palpate for the ASIS. Yes, you can directly touch, but how do you clinically show the palpation of ASIS? Start with umbilicus, down. Okay, palpate. It's all firm. So bony prominence means you must get a hard consistency. Let's say it's firm, firm. Suddenly there's hard consistency. Okay, that is a pubic symphysis. Lateral to that, it's the pubic tubercle. Okay, so from pubic symphysis, just go diagonally. The first bony prominence that you feel, that is the ASIS. That is so from here, you just go diagonally. That is the first bony landmark is ASIS. You palpate. Okay, and inguinal ligament means between the pubic tubercle and the ASIS. That is the inguinal ligament. So you palpate around the inguinal ligament also. Okay. Then you have to palpate for the femoral pulse to look for the vascular sign of Narad. So how do you palpate the femoral artery, surface anatomy? So it's between the pubic symphysis, okay, between the pubic symphysis and the ASIS, mid-inguinal point. Midpoint between the pubic symphysis and ASIS. So when you palpate, just palpate for the pulse, check if it's palpable and its volume bilaterally. Okay, so the idea is to see if there's any diminished pulse. This is, if you find any absent or diminished pulse, it means the vascular sign of Narad is positive. It means that there's some dislocation. It can easily mean that the head of the femur or neck of femur is not in its original position, anatomical. So it could include any dislocation, etc. Then after that, what do you do?
Limb length discrepancy.
Limb length discrepancy. Okay, limb length discrepancy. So how will you check? You want to check for apparent limb length and true limb length. Okay, apparent limb length means, what does it mean? Apparent limb length. You always see, but what does it? Why do you want to measure some apparent limb length? Apparent means it looks as if it's shorter, but it's not short. So where can you get such limb length discrepancy? Apparent limb length discrepancy. When there's contractures. Okay, so usually, let's say fixed flexion deformity of the knee, abduction deformity of the knee. Okay, so there's no actual loss of component of the limb or the bone, but it looks as if it's short. Like let's say you do this. Does it look like as if it's short? That's what you know, apparent limb length. So how to measure apparent limb length? Who wants to do? Who wants to explain? Oh, you explain and I'll